Welcome, everyone. We're doing a focused revision session today on lower extremity wounds and reconstruction, really aiming this at surgical board exam prep.
Exactly. We want to hit the critical concepts, the causes, how we classify things, treatment basics, and those key reconstructive options for both soft tissue and bone. Let's jump right in.
Okay, sounds good. So first up, what are the common causes of these lower extremity wounds we need to have straight for the exams?
Well, you're looking at trauma, obviously, like
Mm,
open fractures. Then there's surgical wound issues, dehiscence, compartment syndrome, too.
right.
Tumors like sarcomas, infection osteomyelitis is a big one, radiation changes, vascular problems, both arterial and venous, and of course, diabetes, lots of potential culprits.
That's quite a list.
Yeah.
So when we face one of these wounds, what are our main goals for reconstruction? What are we trying to achieve?
Fundamentally, we need to debride all the dead stuff,
Mhm.
get a healthy wound bed, then restore stability, structure, blood flow, and function. We also have to any dead space, get durable coverage over vital bits like bone or tendons, and, aim for a reasonable cosmetic outcome too.
Makes sense. So before reconstruction, that initial assessment, what absolutely has to be done?
First things first, especially in trauma, it's the ABCs,
Mhm.
always. Then, a really thorough vascular and neuro exam is crucial. You've got to check the pulses, sensation, motor function,
Mhm.
and assess the wound itself, size, depth, what's exposed. Radiographs are pretty standard, too, for looking at the bone.
Okay. Now, thinking about open tibial fractures specifically, I often hear that the soft tissue damage is the main thing driving prognosis. Why is that?
That's absolutely right. The soft tissue envelope is just so critical for blood supply and healing. Significant damage there really ups the complication risk and makes everything harder.
Right, blood supply. So that leads into classifications like Gustilo and Bird. What are the key differences there? How should we think about them?
Okay, so Gustilo focuses mainly on the skin wound size and the degree of soft tissue injury. Type I, small clean wound, less than a centimeter.
Yep.
Type 2, bigger wound, over a centimeter, but still fairly clean, no massive tissue damage.
Hmm.
Type 3 is the big one, extensive soft tissue damage.
And that's subdivided.
Exactly. I3A means you've got extensive damage, but you can still get coverage. ITB involves periosteal stripping, exposed bone, significant contamination. I3 means there's an arterial injury needing repair on top of everything else.
Got it. And Bird.
Bird looks more at the energy of the injury. Type I is low energy, small wound. Type 2, moderate energy, bigger wound, some bruising.
Okay.
Type 3 is high energy, think. Significant displacement, badly smashed bone, maybe bone loss, lots of skin or muscle damage. Type 4 is extreme energy crush, degloving, vascular injury needing repair.
So both systems basically show increasing severity.
Precisely. They give us a way to grade the injury, which helps predict outcomes and plan treatment. Higher grades generally mean more complications, longer healing times.
Okay. And beyond the classification, are there specific factors with tibial shaft fractures that point towards a higher risk of problems?
Yes, definitely. Things like how smashed up the bone is comminution, how far apart the fragments are, displacement, actual bone loss, distraction, the severity of the soft tissue injury we just talked about, infection, and if the patient has other injuries, polytrauma, those all increase the risk.
And what doesn't seem to matter as much for prognosis?
Interestingly, the exact fracture location or the pattern, like
Hmm.
spiral versus transverse, and whether the fibula is broken or not, those don't seem to have significant prognostic value on their own. It's really about the bone and soft tissue damage severity.
Good to know. Okay, so we've assessed, we've classified. What's the immediate treatment sequence for an open tibial fracture? What's the drill?
All right, the order is pretty clear. First, reduce and stabilize the fracture, often with an X-fix initially.
Right.
Then, restore blood flow if needed. That's urgent. Address compartment syndrome with fasciotomies if it's suspected or confirmed.
Mandatory for compartment, usually.
Yes. And then aggressive debridement and washout of the wound. Crucial. If vital structures are exposed, you need immediate coverage. Otherwise, plan for repeat debridements. The absolute key is getting rid of all non-viable tissue.
Okay, thorough debridement is king. Now, timing of flap coverage for the bad ones, say type 3 and 4. Is there an ideal window?
There's good evidence supporting early coverage, ideally within the first 5 to 6 days. Seems to lead to fewer complications, shorter hospital stays. The idea is to cover it with a muscle flap early during that acute phase before things get really colonized.
So delaying beyond that.
Delaying into the subacute phase, say 1 to 6 weeks, or chronic over 6 weeks, tends to increase complication rates. It gets harder to be sure about bony debridement in the subacute phase.
I see. But I've also seen studies suggesting slightly later coverage can work.
Yes, there are studies showing good results with coverage around, say, 17 days on average,
Yeah.
but the critical point in those cases seems to be absolutely meticulous removal of all questionable bone fragments during debridement.
So complete debridement is the constant factor.
It really is. And then there's Godina's work relating free flap timing to outcomes.
Right. What's the takeaway there?
Simple message. Earlier is better. Group 1, flaps done within 72 hours, had the best outcomes, lowest failure, lowest infection, fastest union. Group 2, 3 days to 3 months, was intermediate. Group 3, over 3 months, had the longest time to union. It reinforces the benefit of early vascularized tissue when you need it.
But have things like negative pressure therapy changed this landscape at all?
They've definitely helped. Aggressive washout and MPWT can help manage the wound bed, maybe buy some time, and allow for successful reconstruction, even if it's slightly delayed into that subacute phase. But they don't totally replace the principle that early definitive closure is often best for severe injuries.
Okay. Let's shift gears to the bone itself. Bony reconstruction, what are the core principles?
It boils down to promoting bone healing. And for that, you absolutely need two things: adequate blood supply to the bone fragments and stable fixation holding them together.
Makes sense. How does the tibia actually get its blood supply? That seems pretty fundamental.
It has three main sources. There's the nutrient artery, usually enters midshaft, supplies the inner two-thirds of the cortex, but is often knocked out in fractures.
Right.
Then you have metaphyseal vessels at the ends, and importantly, the periosteal vessels running on the outside supplying the outer third. These are often preserved and become really crucial for healing after a fracture, especially when the nutrient artery is gone.
And what about callus formation, the different types?
Okay, three main types. Periosteal callus forms on the outside, like an external scaffold, especially important in displaced fractures. It gets its blood supply from the soft tissues and periosteum. Medullary callus forms inside the canal, comes from the marrow. It's quickest and stable, non-displaced fractures. And then intracortical callus is woven bone forming right within the cortex, but it's less significant in adults.
Right.
The key is that periosteum is a source of cells, and the overlying soft tissues provide the blood supply for that important periosteal callus.
Understood. So how do we achieve stability? What are the fixation options?
You've got plaster mobilization, the old Trueda technique in some situations, then internal fixation plates, rods, screws for more rigid stability, and external fixation, which is very common for open fractures initially because it allows wound access. Choice depends on the fracture, the soft tissues, the whole picture.
Right. And if there's an actual gap in the bone, what do we do then?
Okay, for bone gaps, several options. For smaller gaps, say up to maybe 10 centimeter, non-vascularized cancellous bone graft can work, but it needs to be under a well-vascularized muscle flap. Having an intact fibula helps too.
And for bigger gaps?
Then you're usually looking at vascularized bone transfer. A free osseous or osteocutaneous flap fibula is common, iliac crest, scapula sometimes. Weiland suggested this for gaps over 6 centimeters, though union can still take a long time, maybe 15 months.
For distraction osteogenesis?
Yes, a Lizarov technique. For gaps maybe over 10 centimeters, you do radical debridement, make a controlled bone cut, or corticotomy. Wait a week, then distract slowly about 1 millimeter a day. New bone forms in the gap. Frame stays on for maybe a year.
What are the pros and cons there?
Big advantage is you get anatomically correct bone. Can close soft tissues over it. Often no transfusions needed. But contraindications include really massive defects, maybe over 12 centimeters, or poor quality remaining bone. And complications like pin infections, joint stiffness, pain are definitely concerns.
Okay. Quickly, open joint injuries, key management points.
Acute management is all about preventing septic arthritis. So get cultures pre-op and intra-op, broad-spectrum antibiotics, early copious irrigation, debride the joint and soft tissues thoroughly, first-stage closure, usually without drains.
Any specific bugs to worry about?
Pseudomonas and Klebsiella are common culprits and can be nasty in a joint.
Got it. Let's move to soft tissue reconstruction. Goals and principles.
Goals are straightforward. Stable wound coverage, decent appearance, and minimizing donor site problems. The principles are, again, thorough debridement, maybe multiple times, control infection with culture-specific antibiotics, and crucially, harvest your flap tissue well outside the injured zone.
Okay. Thinking about local flaps for the leg, are there workhorses for different areas? Say, the upper third.
Upper third, the medial head of the gastrocnemius is the go-to muscle flap. Big, reliable blood supply, usually minimal functional loss. Scoring the fascia can give you extra reach. Lateral gastroc is smaller, but also an option. Proximally based soleus can reach too.
And the middle third?
Middle third, the soleus is probably the main workhorse. Gastroc heads might reach sometimes. For smaller defects, maybe flexor digitorum longus or extensor digitorum longus, but you have to be careful about function, especially preserving the peroneal nerve with EDL.
Right, always considering function. What about the lower third? That's notoriously tricky for local options.
It is. Local muscle options are limited down there. Medially, maybe FHL, FTL, tibialis anterior. Laterally, peroneus brevis or tertius for small defects. You might consider things like the extensor digitorum brevis island flap. Fasciocutaneous options like the lateral supramalleolar flap exist but cover smaller areas.
So often needing something more.
Often, yes. Which brings us to distant flaps. The classic cross-leg flap is rarely done now with free flaps available, higher necrosis rates too. Perforator flaps are a big area now, especially useful distally.
Like the sural artery flap.
Exactly. The reverse sural artery flap is common for distal defects based on peroneal artery perforators. But you have to be careful about potential venous congestion or pedicle compression. Propeller flaps, islanded on a single perforator, are another option, but again, they can have partial loss issues and a steep learning curve.
So complication rates can be higher with some of these perforator flaps?
This certainly can be. Requires meticulous technique.
And then for the foot itself?
Often split-thickness skin grafts work well, even on weight-bearing areas if the bed is good. Island flaps like the instep flap can provide sensate coverage. Toe fillet flaps are an option in specific situations.
Okay, so when local options aren't enough, especially lower thirds, that's when free tissue transfer comes in.
Precisely. It's indicated for large defects, especially distally. When you don't want to sacrifice local tissue, if there's dead space after debridement, if local tissues or vessels are damaged, or if local flaps have failed.
What are the common free flaps we should know for the lower leg?
The big ones are latissimus dorsi, rectus abdominis, serratus anterior, gracilis, scapular parascapular flaps, radial forearm, and the ALT anterolateral thigh perforator flap. Lots of good options depending on the defect.
And the anastomosis, where do we typically do that?
Traditionally, the teachings to do it outside and proximal to the zone of injury, using healthy vessels. You might need vein grafts. End-to-end or end-to-side are both options.
Any change in thinking there?
There's some evidence now suggesting distal anastomosis can be safe if you've confirmed good flow across the injury zone, maybe with angiography or palpable pulses, but you have to be sure. End-to-side is often favored, especially if distal runoff is compromised, to preserve flow to the foot. Use angiography or CTA liberally if in doubt.
Right. And what about integra? Where does that fit in?
Integra, the bilamate neodermis, can be used on pretty much any clean vascular wound bed. Even exposed bone if the periosteum is gone but the bone is viable. It creates a dermal layer you can graft onto later. It's a useful tool.
Okay, let's quickly cover a few other key topics. Tissue expansion.
In the lower extremity, it's mainly for resurfacing unstable scars or defects, usually works better in the thigh or buttocks. Below the knee, complication rates, especially infection, tend to be higher, often due to dissection issues. Use with caution there.
Amputation. When is it considered?
It's a functional decision. Criteria often include things like multiple compartments involved, multiple tibial vessels injured, failed vascular repair, a non-viable foot, severe crush or muscle loss. Patient factors like age and baseline function matter too. Sometimes, amputation provides a better functional outcome than a long, painful, ultimately non-functional limb salvage.
Important point. Compartment syndrome.
Yes, always be vigilant. Incidence with tibial shaft fractures is significant, around 9%. Remember, an open fracture does not rule out compartment syndrome.
Key signs.
Pain out of proportion, pain with passive muscle stretch, really tense compartments on palpation, paresthesia often diminished simple touch first, not just saphenous loss, and then later signs like paralysis and pallor or pulselessness. Early diagnosis and fasciotomy are critical.
Okay. And osteomyelitis.
Bone infection can be caused by retained dead bone, infected scar, dead space, or just inadequate soft tissue coverage. Staph aureus is the most common bug. Incidence in severe open fractures is significant without antibiotics, but prophylactic antibiotics help a lot.
Treatment.
Aggressive surgical debridement of all infected bone and soft tissue. Obliterate dead space, get stable, vascularized soft tissue coverage, often with a muscle flap, and long-term culture-directed antibiotics. It's often a balancing act between fixation, coverage, and clearing infection.
How does NPWT fit with osteo?
NPWT can help manage the wound after debridement while waiting for definitive coverage, often used concurrently with antibiotics. They can help repair the bed.
Right. Finally, chronic lower extremity wounds. What are the common causes?
Big categories here. Diabetic foot ulcers, vascular insufficiency, both arterial and venous stasis, lymphedema, chronic osteomyelitis recurring, cancer like Marjolaine's ulcer in an old wound, radiation changes, and vasculitis.
Evaluation basics.
History's key comorbidities like diabetes, claudication, rest pain, wound onset, previous treatments. On exam, look at size, depth, location, check pulses, sensation with a filament, skin temperature, signs of venous disease like hemosiderin or edema, ABI, labs like glucose, A1C, radiographs, cultures, maybe biopsy if cancer's suspected.
And briefly, key features for diagnosis and treatment for the main types.
Okay. Diabetic ulcers, often neuropathic. Loss of protective sensation is key. Arterial, painful, punched-out appearance. Signs of poor perfusion like shiny skin, hair loss, abnormal pulses, low ABI, needs revascularization. Venous stasis, typically in the gaiter area, associated with edema. Skin changes like lipodermatosclerosis. Compression is key, maybe vein surgery. Lymphedema, massive edema, skin changes, need compression, sometimes surgery like debulking or bypasses. Osteomyelitis, often a draining sinus, history of trauma hardware, needs debridement, antibiotics, flap coverage. Cancer unusual appearance, non-healing, biopsy is crucial, needs wide resection or amputation. Radiation history, fragile tissues, maybe hyperbaric oxygen first, then resection and free flap, often needed as local tissue is poor. Vasculitis, systemic symptoms, often very painful. Biopsy confirms, needs rheumatology input, steroids or other agents.
Wow. Okay. That's a lot to cover. So to quickly recap the absolute must-knows for exams, radical debridement is fundamental.
Absolutely.
Early stable soft tissue coverage generally reduces complications. NPWT is a useful adjunct. Know your workhorse local flaps. Gastroc for upper third, Solus for middle third. The free tissue transfer is often needed for the lower third.
Right.
Integra is an option for clean vascular beds. Be cautious with tissue expansion below the knee. Always watch for compartment syndrome. Amputation can be a good functional choice. And know the characteristics and basic management principles for chronic wounds like diabetic, venous, arterial ulcers.
You've got it. That covers the core high-yield points relevant for the boards.
Great. That brings us to the end of this deep dive. We hope this focused revision has been helpful for everyone preparing.
Definitely. Keep reviewing these concepts and integrating them into your overall knowledge base.
And just a final thought to leave you with. Considering the increasing use of biological scaffolds and advanced wound dressings, how might the traditional algorithms for lower extremity reconstruction evolve in the coming years? Something to ponder.
Good question. Technology is always advancing. Best of luck to everyone with their exams.